or meconium stained amniotic fluid, or whatever's in their mouth. So use a bulb syringe. Is that a familiar device?
Yeah.
Squeeze it and suck out everything that's in their mouth. Okay, mouth, then nose, just like the alphabet, M and N. Okay, if you suction out their nose first, what are they probably going to do? And inhale everything that's in their mouth. So mouth, then nose. Okay, parents should know how to use a bulb syringe too, because very beginning. Okay, they're gaggy, they're spitty, trying to get rid of all that amniotic fluid, and they may have little gagging events without the nurse present. So the parents should know how to use a bulb syringe so that they can clear the airway. And they'll be happy they know how to use it when the child is 9 months old and snotty from their first cold. They have those other suction things now too, those nose breathers or whatever.
Oh, they're so weird.
Mentally, I can't do it.
No. Were you sucking
Nose
yourself?
freedom?
Yep.
You suck it out with your mouth. It doesn't. There's no actual contact.
Apparently.
There's like a valve.
There is a valve.
Yeah, there's a little filter.
There's a little filter.
Yeah.
I used to joke around. I wanted like wall suction at home. I just wanted to like turn a button on it.
Somebody's brain.
Yeah, an electric one. I'd love to cut one of those things open though and see what's inside after a while. Okay, after our scores, basically, we went from inside to being outside. Okay, so we have our score. We are evaluating heart rate, reflexes, and color. They get a score at 1 minute of life, and then again at 5 minutes of life. They may do more if both of those scores are not so good. Right. So after score is going to be reviewed when the child's admitted to the nursery. So we want to see, like, gee, how did this baby do? Do we need to monitor this baby more closely for anything? If APGAR scores are really bad, then they're going to go to the NICU anyway for closer observation, if we have any concerns. Okay, circulation. Okay. When that cord is clamped and cut, their lifeline is gone. So they're now completely dependent on their own circulation. Okay, they don't have the placenta anymore to do the work for them. They have approximately 300 mLs of circulating blood volume. That's not a whole lot. I feel like one of the little regular size, like Poland Spring water bottles is about 240 mLs, I think. So they don't have much more. Murmurs are not common in newborn. Lovely openings that have to close. Remember, they have their 3 shunts. Okay, so it's not uncommon for those to close, back open, close, kind of go back and forth for a little bit. Any murmur that you hear should be evaluated. The pediatricians are good at determining whether or not murmurs need further evaluation with like an echo, a cardiac echo, just based on what it sounds like in the location on the chest, right? We know if we hear a murmur up here, it's probably just a flow murmur. Okay. Or they may just wait a little bit and see if the child outgrows it. Because if they're stable, otherwise it's not that big of a deal. It's not uncommon to have a murmur. All right, keeping them warm. We've talked about keeping them warm before. Remember, keeping them warm helps prevent other complications such as hypoglycemia, respiratory distress. Their heat regulating system is pretty immature, so they can drop their temp pretty quickly. Temperature in the room and the number of blankets can influence body temperature as well. If your baby, if you have too many clothes, too many heavy blankets on them and they get warm, now everybody wants to do more blood, like is something wrong with them? Why are they so warm? We can't just say, oh, they're overdressed, right? So you may buy a septic workup if your child's too warm just because they're overdressed. And we usually now, when the babies come into the nursery with like all these extra blankets on them, we take them off. But they're too warm. Usually, whatever you have plus a layer is sufficient. Hands and feet are not used as guides. Their hands and feet are always a little bit on the cooler side. They have that acrocyanosis, so they're not only are they on the cooler side, they're also on the bluish side. So we don't use the hands and feet to determine whether or not the baby's warm. How do we help keep them warm? What's one of the things we can do to keep them warm? Swaddle. Yes, when the first we're covered their head, but once they have a bath, we don't put hats on it because it's a not safe sleep friendly. Right, the hat could slide down over their face. Skin to skin. Right, kangaroo care with mom.
Maybe smell right? Baby,
All right. So now we'll go over vital signs and what else we have. Vital signs, skin issues, jaundice. Obtaining pulse rate, respirations, and temperature. We have discussed this in other chapters. Heart rate and respirations are done preferably before you disturb the baby too much, because once you wake the baby up and they start crying, those numbers are going to be even higher. Okay. Normal heart rate is 110 to 160. Normal respiratory rate is 30 to 60. Blood pressure varies, roughly 80 over 46. I told you I will not ask you about blood pressure. Temperature is taken either temporal artery thermometer or axillary. Okay. We need to notify the provider or report anything that's outside of the normal range. So a heart rate that's below 110 or over 160, respirations below 30 over 60, any noisy respirations. Watch that video and talk to the baby that was grunting. Right, so if they sound like that, we should report that. And then high or low temp. In the musculoskeletal system, their bones are soft. So they're composed mostly of cartilage. So the skeleton's flexible, the joints are elastic to accommodate passage through the birth canal. That's why, we don't stress too much if they have a fractured clavicle from a shoulder dystocia, because everything's very flexible and it'll heal pretty quickly. Due to the ease of molding, we want to change their position pretty frequently. Okay, what happens when you leave when a baby lays in the same spot all the time? Flat heads. That's the biggest concern. Their heads get flat. So you want to make sure you rotate them, change their position. I think I joked around that I used to put my kids to bed and I'd rotate their heads every night. Like one night they face this way, the other night they face this way. So that their heads would stay nice and round. Some babies may not turn their head, or they may favor one side due to tightening of the muscle. It's called torticollis. We'll talk about it in these chapters. But so it's not that they don't get the opportunity; it's that their muscle's too tight and they can't look all the way to the other side, and they end up favoring one side, and then they'll have flatness. Development of control proceeds from the head to the foot and from the center of the body to the periphery. And if you think about developmental milestones that babies hit as they age, that makes sense, right? So from top to bottom, they start to have control of their head, they have control of their torso, they can sit up, their fine motor skills, they can reach for things with their hands before they can crawl, stand, and walk. So from top to bottom and then from the center out. Core before fine motor skills. All right, length and weight. Average length is 46 to 55 centimeters, so 19 to 21 and a half inches. There's going to be babies that are smaller and babies that are longer. Weight varies from 6 pounds to 9 pounds. In general, girls weigh a little less than boys. African American, Asian American, and Native Americans are also somewhat smaller, usually. Infants lose about 5 to 10% of their birth weight. Even babies that are 600 grams will lose 5 to 10% of their birth weight. Maybe even more if they're preterm.
My son never did. My son never did. My oldest.
He didn't lose anything?
No, it was ridiculous.
Was he term?
Yes.
Got him right off the gate?
Well, he was 9 pounds when he was born.
Yeah.
And then he didn't even, they were like, the doctor was like,
Looks like my steak dinner.
Yes, that's how he was.
What is this formula nonsense? All right, they do lose weight though. Not all the time, but they can lose up to 10% of their birth weight for a term infant. It would not be unexpected, and we do not stress about it if they lose 5 to 10% of their birth weight. Okay, usually there's fluids that are lost, they pee, they poop, there's withdrawal from maternal hormones that can cause the weight loss to occur. Okay, usually it normalizes after 3 to 4 days. They'll stop losing and they'll kind of even out, and then they start to gain. By 10 days, 2 weeks, they're usually back to their birth weight. They are weighed every day. It's a night shift job at pretty much every hospital. Weigh them every day at night. And weights documented in kilograms so that we can do safe medication dosages. Right? We dose medication for infants based on kilograms. And we'll go over that in chapter 22. GU, the kidneys are not fully developed. They have a hard time balancing, fluid excess. Just good eyes and nose, keeping track of how many times they void. Make sure we know when they void for the first time. Make sure everything's working, and then documenting wet diapers. That's all we need to do like that. All right, male genitalia is developed at birth, but maturation varies. The testes descend into the scrotum before birth. Sometimes they stay in the abdomen or the inguinal canal. Right? It's usually called undescended testes, cryptorchidism. Good prognosis. When the child gets a little bit older, they retrieve it and put it where it belongs. The urethral opening should be at the tip of the penis. Presence of white cheesy substance may be found under the foreskin. That's thought to be bacteriostatic. You may have learned about like hypospadias and epispadias in A&P. That is something to keep in mind with if the parents want the baby circumcised, which we'll talk about next. If they have a hypospadias or an epispadias, they will not be circumcised at the hospital. Okay, that'll be done outpatient by a urologist because they're going to do a reconstruction of the whole urethral opening and make sure it's centered. Okay, so they may need the foreskin for that. As far as circumcision goes, it's surgical removal of the foreskin. There's advantages and disadvantages. It's really, like pediatricians say, it's completely up to the parents. Right? Nobody's going to say you have to do it. Nobody's going to say you shouldn't do it. It's really personal choice. It's a minor surgical procedure, so infection and hemorrhage are always a concern. Advantages: possible prevention of penile cancer, fewer UTIs, fewer occurrence of sexually transmitted later on in life. Prior to circumcision, the infant should be stable. Be surprised, like a lot of babies come to the NICU and they're like on respiratory support and they're on IV fluids, and the parents are like, when's the circumcision? I'm like, in 3 months. Like, this is the last thing I'm worried about right now is when this baby's going to be circumcised. Like, that'll be right before they go home. We don't have to worry about it right now. Babies placed on a circumcision board, we'll look at a picture in a minute. Usually, there's different devices that can be utilized for circumcision. It depends on what the provider prefers. Vaseline and gauze are usually sufficient for a dressing. And it's nursing's job to make sure the parents understand the procedure, make sure that we don't get consent, but we need to make sure it's signed, and prep the newborn. Afterwards, we want to make sure the baby pees. They could simply not be able to pee just from swelling from the procedure. Okay, monitor bleeding, make sure it doesn't look infected. So there's different devices here. This is the circumcision board. They're usually more pissed about being strapped to that board. They don't want to be strapped down. Most of the time now, we really just strap their legs and we'll swaddle their arms. They're happier that way. They get a lidocaine block, and then they have their circumcision. It's very quick. Who do you think does the circumcisions? Your OB. The one doctor who doesn't deal with penises ever. Does your baby circumcision. No, your OBGYN will do your baby circumcision. It's crazy, I think. Like,
Very interesting.
unless there's, something else going on and we need a urologist to do it. Sometimes the baby's in the NICU, if they're there for a long time, the NICU doctor, the neonatologist will do it just because the OBs are like, no, like that baby's too little, or they're kind of beyond that. But in a term baby that's in the nursery, your OBGYN is gonna do it. It's crazy. All right, female genitalia may be slightly swollen. There's lots of extra fluid. Some of that swelling will go down as the baby starts to diurese and pee it out. Thin, white, or blood-tinged mucus may be present. This is alarming for parents. Okay, it's called pseudomenstruation. It could be the result of, hormone withdrawal from the mom. They have like blood-tinged mucus, and parents are completely paranoid about it. They're so upset, because it's blood and they're not expecting to see it. But it's very normal for the baby to have. Okay, just like we advise females to clean from front to back, same thing for baby girls, or top to bottom, right? Because you're changing a diaper, so make sure you're wiping top to bottom. Skin tissue turgor refers to hydration or dehydration of the skin. So skin turgor is a familiar term. Pinching the skin to see if it's tense, that can help let us know about hydration and dehydration. Skin of the newborn Caucasian infant is red to dark pink. Skin of African American infants is a reddish brown. Infants of Latin descent may appear to have olive or a yellowish tint, which can be tricky if you're concerned about jaundice, because they can have kind of a yellowish undertone. Body is covered with fine hair called lanugo. Okay, that will go away as the baby gets a little bit older. Vernix also covers the skin. It's a cheesy substance. Okay, it helps protect the skin from the irritation and the effects of a watery environment in utero. White pinpoint pimples called milia. They look like little tiny whiteheads. If you've ever been around a newborn baby, you probably have seen them. Usually like on their nose or their chin. Those should not be popped. They will go away on their own. And they can have similar, I don't want to call it a lesion, but similar to milia, they can be found in the mouth, usually on the hard palate, like the roof of the mouth, and in that situation they're called Epstein's pearls. Yeah. So here's some pictures of that. So this baby has lanugo, that's that fine hair, you got some hairy shoulders there. It'll go away. Probably some of the sideburn effect too will probably go away. This baby needs a bath. That's a lot of vernix. The thing with vernix, you don't want to aggressively try and scrub it off the baby. It's very sticky. And if you're trying to rub it off aggressively, now you're possibly damaging their actual skin. So you give them a bath, whatever comes off, great. It'll absorb over time. This baby has milia. See those little white spots there. Skin turgor. Someone should hydrate that child. Although it looks like it also has an IV. That looks like an IV right here. So maybe he's getting some IV fluids.
Yeah, but he looks like he's swollen.
Hmm? His tummy's pretty round. It's probably like failure to thrive. We'll talk about in a few months. And then Epstein's pearl, you see those little white pinpoint pimples on the roof of the mouth there. All right, some other skin conditions. These are kind of a nice to know. You don't have to worry about being, well, acrocyanosis is not a nice to know. It's a need to know. But we'll start with stork bites. Stork bites are flat at areas. They're usually seen at the nape of the neck. Sometimes they can be seen on the eyelids. They can really be seen anywhere. They're the result of a dilation of the smaller vessels. They will fade over time. Okay, Mongolian spots are bluish discolorations of the skin. These are common in infants of African American, Native American, and Mediterranean descent. These are usually found over the sacral and gluteal areas, so you may see them on like their butt or the backs of their thighs. Those will also go away over the first few years of life. Acrocyanosis we've talked about, bluish color of the hands and feet, okay, just from poor circulation. And then desquamation is peeling of the skin. Higher contact areas like the nose, the knees, the elbows, the toes. Those are in contact with different fabrics and everything when the baby's born. So their skin can start to peel. So here's some examples of that. So see, when we're looking at acrocyanosis, the baby's hands are not blue, their hands and feet are not blue, but compared to the rest of their body, they have a bluish tone. Okay, totally normal for the first 24, 48 hours or so, as their circulation is kind of perfecting itself. Stork bites right here. This baby's got a Mongolian spot. These two will fade or go away. And then this baby has desquamation or peeling of the skin. So those are terms that I would be familiar with. The next set of skin lesions you don't have to worry too much about. Just go over them quick. Cutis marmorata is a lace-like red or blue pattern on the skin surface. It's also called, also referred to as mottling. This is usually a response to the baby being cold. So warm the baby up, maybe. That'll help with that. Sometimes they have a lot of mottling too if they have a fever, because their circulation's affected, and it can cause some mottling. Erythema toxicum is also referred to as newborn rash. When remember they've gone from a nice protected environment in utero, and now they're out here, and we're putting clothes on them that are made of various fabrics, hopefully just cotton, might be nice. Scents, perfumes, facial hair, like maybe dad or grandpa or somebody's got a little scruffy beard, and that rubbing, like their skin is very sensitive. So this newborn rash happens pretty often. They have little like red papules that have like a little white center. Those also look like little whiteheads, so resist the urge to pop them. Don't pop them. They'll go away eventually. Harlequin color change is kind of interesting. I've only ever seen this like actually in person once. The baby is literally two different colors right down the middle. They're very red on one side and very pale on the other, and it's a vasomotor response. Usually it can be fixed with like repositioning the baby. Okay, port wine stain, that's a birthmark. These birthmarks start out as flat birthmarks, and as the child gets older, they get a little bit more vascular, a deeper purple to bluish color. A lot of times people that have those birthmarks need to have laser surgery on them. So that's that port wine stain there. So flush with the skin, red, doesn't look like terrible right there. But as I said, as they get older, it's going to look more vascular and veiny and more purple. And they might need laser surgery. There's that mottling that can occur. See, they have that little like lace-like pattern on their legs. Probably from being cold. Harlequin color change, right down the middle, two different colors. And then the erythema toxicum, that newborn rash. Characterized by a yellow tinge of the skin. We're talking about jaundice in this afternoon. The baby in utero has more, the intrauterine environment is a lower oxygen environment. Okay, so they have more red blood cells to circulate. When they're born, they don't need all those extra red blood cells, so their body starts to break them down, but the liver, can't necessarily handle all of those red blood cells breaking down at the same time. Okay, so that all of that hemolysis that happens causes an increase in bilirubin. Okay, and bilirubin is what makes the skin jaundice or yellow. Some genetic and ethnic factors can affect the severity. I would not ask you about bilirubin levels because those are literally specific to every single patient. We have you can Google it if you want to see. It's called BiliTool, BILITOOL.com, and you literally plug in the gestational age of the baby, how many hours old the baby is, if there's any risk factors, and it'll tell you what level is not good for that baby or what level would require treatment. Okay, so I would never ask you about bilirubin levels because it varies. And if you ever saw a question that had bilirubin value on it, it would give you the normal range next to it. Okay. So we're always looking for jaundice. We'll look in things like the whites of the eyes. Usually you can see it somewhere on the face first. Mucous membranes will turn jaundice as well. We measure jaundice. We don't use this icterometer anymore, so I'll skip that. But a transcutaneous bilirubin measurement. It's a little machine that scans the skin, and it gives us a number. Okay, depending on what the number is, we may do blood work to confirm if we're concerned that the level's too high. But the transcutaneous bilirubin is non-invasive and an easy way to monitor babies without constantly having to poke them for blood work to check actual bilirubin levels. Okay, so if that's high, then we'll do blood work. Bathing, they don't need baths every day. You're cleaning the dirtiest part of the baby every like 6 to 8 times a day when you change their diaper, right? Unless they're rolling around in the mud outside, they don't need a bath every day. 2 to 3 times per week should be sufficient. They lose a lot of their body temp through their heads, especially in the beginning. So generally you kind of wash the body and then take the baby, wrap the baby up, and then shampoo the head so that they don't get too cold all at once. So we usually save the shampooing of the head till last. Preferably don't give them a tub bath until the cord falls off. Okay, remember the faster it dries up, the faster it's gonna fall off. So just doing sponge baths will help that cord dry up and fall off faster. Stooling, this chapter done before dinner break. The intestinal tract functions as an outlet for amniotic fluid as early as the 5th month of life. Normal functions of the GI tract begin after birth. So meconium is the first stool. It's very dark, it's sticky. It's like a bear to get off their skin sometimes if it's been in their diaper for a little while. Very sticky and tarry. That is usually past 8 to 24 hours after they're born. Some babies pass meconium in utero. And then we have to worry about a whole nother list of potential complications that go along with that. Okay, stool gradually changes during the first week of life. They become loose and more of a greenish yellow with mucus. Stools of a breastfed infant are bright yellow. They're very soft and tasty. Sometimes they look seedy, like they have little seeds in them. They poop all the time. They will poop like every diaper change when they're breastfed. Bottle-fed babies can go a little bit. Sometimes they spread them out a little bit more. Putty-like stools or diarrhea and bloody stools are abnormal. Those should be reported to their pediatrician. Putty like gray, colorless stools. When in doubt, save it. Bring it to the doctor. Everybody has smartphones now. You can take a picture. They would rather see a picture than hear you probably try and describe it, because then at least they can see for themselves, right? Because bloody stools, yeah, like a parent may see like a tiny little streak of blood and be like, oh my God. Like, well, maybe the baby's not tolerating something they just ate or something you ate. Like, it's not as alarming to them. So they'd rather see a picture, I'm sure. I used to text my pediatrician, is this normal? I knew it was, I just needed some validation. Constipation, sometimes they don't go for a few days. It's not that big of a deal. especially when they do go, if the volume is large and the stool is soft. Okay, for adults too, if their constipation would be like small, dry stools, like little pellets, that would indicate that the child's constipated. They're not getting enough hydration to have to soften the stool. Okay. Even if five to 6 days go by, yeah, they're probably going to be pretty uncomfortable. But they always kind of look like they're straining anyway. Their abdominal muscles are pretty weak. They don't really bear down that well. So they always look like they're trying to work out a poop. So even if 5 to 6 days go by, it's not constipation unless it's very hard and dry when they do go. If they are old enough to be eating solid foods, you can give them like prunes. You can put prune juice in. You can, they can talk to the pediatrician about putting a little prune juice in with their formula or breast milk too, if they're really struggling. All right, hiccups are normal, just like when we get them. There's not much you can do to make them go away. They just go away on their own. Digestion. Babies have an immature cardiac sphincter. It's not uncommon for them to spit up, okay? When we get into our PDGI chapter, we'll talk about like esophageal reflux and GERD. Spitting up is not that big of a deal. It's more of a concern if they're spitting up and it's affecting weight gain. Because a lot of times at the beginning, it's usually because they're eating too much. They don't stop eating. They'll just keep going. Right, a lot of times, especially in the beginning, because it's that sucking reflex, and they're just going to keep sucking and sucking and sucking, and then now they're overfed, and it's all got to come back up. Vitamin supplements, sometimes we'll give a multivitamin after the baby's born, especially if mom is breastfeeding. They'll have the mom give vitamin supplements. All right, preventing infection. They do get some immunity from that's crossing the placenta. They have their own immunity that's produced by the newborn that can help fight some infection. They get some immunity from breast milk as well. You don't have to worry about which immunity comes from what. I want to ask you about it. Right. But what's the main way to prevent infection?
Washing your hands.
Washing your hands. Okay, keeping your hands clean. Tell the parents to wash their hands. Use common sense when you bring a baby home from the hospital. If you're, visiting family or family's coming to visit you, make sure they wash their hands or keep some hand sanitizer around. I would hope that nobody would come over and visit a newborn not feeling well, but people are selfish, and if they want to see the baby, they'll go see the baby no matter what. Every baby has their own stuff. So you put a bunch of diapers in the crib, right, and they bring it to the mom's room, and then the baby goes home. Everything you put in there is garbage or laundry. So send it home with them. We're not going to stack up the diapers and then use the diapers for somebody else, or even the blankets that are in there, the bird cloths. Once that baby is sent home, the whole crib gets emptied. Anything that's, single use goes in the garbage, and then blanket, all the linen's gonna get washed. And nothing's reused. All right, discharge planning and parent teaching. One more slide. Begins on admission. Remember, you don't have much time. Maybe 24 hours. Hopefully a little bit more. But, we have pathways that can help guide our teaching. Making sure they know how to do a bath, how to take care of the umbilical cord, circumcision care if applicable for that child, what to expect for feeding and diaper changes. We're going to give all these directions written too, because they're not listening to anything you're saying when they're getting ready to pack up and go home. Right? They're very excited about going home. Safety measures, including position for sleep, making sure they know it's safe sleep. Right? Back to sleep, on their back, in a crib, firm mattress, nothing in the bed, no bumpers, no blankets, no stuffed animals. That's all for safe sleep. Immunizations, support groups, that there's breastfeeding support outside of the hospital setting for moms that are breastfeeding. Return appointments for well baby care, they'll usually tell you before you go home, the doctor wants to see you in 2 days. And the doctor, you just call and make an appointment. Sometimes they'll make it for you. Telephone number to the nursery. I can tell you if anybody calls the nursery and say, I got discharged yesterday, my baby's doing this, they're gonna say, call your pediatrician. How to use car seats, safety. I told you guys about the family I discharged from going out to the car. Out to the car with them. And the dad said, well, mom can't keep the baby on her lap. And I was like,
Oh my God.
oh my goodness. I said, no. So the baby has to go in the first. And then they started to facing forward. And I was like, oh my God. It's like just gray hairs everywhere.
Me and the baby will went back into the hospital.
And I said, that's the last time I'm doing a discharge.
Most police departments will do it.
And the firehouse.
Police departments, firehouse, will install car seats. You can get, they don't like us doing them, without any kind of midnight type. Right. So making sure they know how to use a car seat. Signs and symptoms of problems, you can contact your pediatrician. Okay, call your pediatrician if there's a problem. Refusal of 2 feeds in a row. If the baby skips a feeding, it's not that big of a deal, especially if it's at night. Like eventually they're going to go the whole night without eating, hopefully. That's the plan. But if they skip 2 feeds in a row, especially as newborns, then the pediatrician should be notified. Oh, furniture and clothing. They should have their own, they don't have to have their own room, they should have their own space. Meaning not mom and dad's bed. So it could be like a co-sleeper that pulls up to the bed. There's a lot of things that parents use that are probably not approved, like those DACA tots that go in the bed, but you're still in the bed with your comforters and your blankets and, listen.
The thing with the light and the music.
The advice is that they should be in their own sleeping space. What the parents do when they go home is at their own risk. These are the directions that we provide. Keep things nearby that they might need, like diapers and all that stuff, right? You don't want to have to leave the baby to go get supplies. Clothing should be soft, washable, nice fabric so that they're not like getting too many rashes. Think about extra buttons and bows, like things that may fall off and become a choking hazard as the child gets older. Take that into consideration. Anything that parents don't have that they need to be able to be discharged, social work in the hospital can usually get it. Okay. Need a crib, need a car seat, they can get it if the parents need it. And that's it. It's for this chapter. So we'll start chapter 13 when we come back from dinner. You guys can stay till 7:15 if you want, because we're a little bit ahead. We are ahead on time. And I need to charge my computer.